Okay, chapter 4, cultural, spiritual, and environmental influences on the child. Again, the disclosure statement, I don't own this material. Under fair use, I am providing lecture content for only my nursing students using this material. All content within is only for educational purposes for nursing students and does not provide medical advice. So, just some thoughts on, let me just move this real quick, make that a little bigger for you. So, identifying individual cultural bias. The first thing you have to do, if you remember back to HCR 230, if I taught you guys that course, I believe I did, is to identify your own cultural bias. If there are people that you cannot take care of, it's better to say that to the staff nurse, the charge nurse, than to go in there and really cause problems. As a nurse, you should be able to de-identify and take care of anyone, even including a serial killer. So, that being said, you have to really look at your own cultural biases and make sure that you're not bringing that into your care. We're going to talk a little bit about Langer's theory and how it can be used to plan care, and cross-cultural communication, body language, nurse-patient relationships, and multidisciplinary relationships between the caregiver family and the pediatric patient, and identify some language barriers and describe the importance of doing so. Identify some characteristics that determined by culture, components involved in a cultural assessment, how spiritual beliefs might affect the care of a child and family, environmental and societal considerations when caring for a patient. So, culturally competent care. One might think that if you have studied some cultures that you are now culturally competent. We now know that that's probably not true, and that even if you have vast knowledge of different cultures, you're still on a learning continuum. So you're constantly learning about cultural differences, and bringing those into your realm. Children learn about culture from their parents and their caregivers. That just says it all right there. So some people are more closed to other cultures based on their upbringing. It may come towards you or it may be coming from you. So just being careful with that. We definitely want to make sure that we're in an ongoing capacity of a healthcare system, organization, and professional to provide for diverse patient populations. The end goal of all of our nursing is high quality care that's safe, patient, and family centered, evidence based, and equitable. So if you cannot do that, or you choose not to do that, nursing may not be for you. You have to be aware of your own bias and consider the patient and family experience of the care that they are receiving. Reality is what they say it is, right? So just being able to self-identify, what do I believe in? Am I familiar with the patterns of child care with different cultures? Am I aware of my biases? In what way am I biased? How do I resolve my biases? Okay. So Dr. Leninger, here in the middle of page 57, transcultural nursing occurs when the nurse incorporates the patient's culture into the plan of care that he or she provides. So she actually termed the founder of cultural nursing care, and her theory has been able to capture and articulate how culture affects health. So her website is available and has tons of material in there. We also use it now in the HCR 230 course. So there has been racial change in America. The racial demographics of individuals living in the US has changed. Half of the children living in the US were classified as white or non-Hispanic. The racial changes that have occurred have also brought forth health disparities. So underrepresented minorities occur in a higher incidence now and have poorer health outcomes. So we're really looking for those disparities in care, like race, religion, socioeconomic status, sex, age, mental health, and cognitive, sensory, and physical disabilities, sexual orientation, and geographical location. So one would think that Tampa wouldn't have that much of a problem with this, but it's actually quite a big melting pot of people and cultures from all over the world. So you're really going to see that here in school. If I took you up to Plattsburgh, New York, you would not see that racial diversity. So everybody has different thoughts on the mix of people that are in their area. Health equity is not necessarily equality. Equality is giving everyone the same. Equity is that everyone has what they need to be successful. So, do we really provide what's needed to be successful to people? People who cannot afford insurance do not have the same health access. So, agent policies that need to be changed a little bit, like visitation, unrestricted parent, caregiver, grandparent visitation, visitors allowed during the child's waking hours. Visitors must be free of contaminated diseases, communicable diseases, the opportunity for the client to get rest, good hand hygiene, family privacy, patient held and cared for by family members, proper seating and space for socialization to occur, family allowed to take the patient out of the room when possible, and play items should be used for diversion techniques. Okay. So really think about some of our policies. Some of our policies are outdated. We really need to think about what we are doing in providing them care. So staff education, obviously, you may be called upon to bring in a presentation for more cultural competence in your area, especially if you are of another culture. We definitely want to bring that in. So some best practices for communication, kind of like in the last chapter. Don't interrupt when conversing with the client. Let them have their say, even if it takes a longer time to get their thoughts together. Think about the gender of the care provider. So is it a female matriarchal or patriarchal society that you're dealing with? Use a certified interpreter at all points in time. That's always going to be the answer on the NCLEX. Speak in a tone that's appropriate for the situation and provide undivided attention to the parent and the family members. Remember that body language is different in all cultures. Oh, sorry, I'm not keeping up here. Remember that body language and touch awareness are not necessarily the same in all cultures. So being very aware of eye contact, both direct and indirect. So in my work up in Montana, I was constantly asking people, what's up with no eye contact? And in fact, the Native American population up there, they revere you as close to God as possible. You're right there at God's right hand. So that's why they show respect by not looking you in your eyes. So don't expect eye contact all the time. Nodding of the head, touching the top of the head can really be a problem. So when I was in South Texas, you never touched the top of the baby's head. You were giving him bad spirits. So just be careful with that. You don't always want to do that. Shaking hands, especially the member of the opposite sex, might be very not kosher. And hand and arm gestures, just be careful with what you're doing. Be aware of some of these things can really be off-putting to other societies. You want to establish a nurse-patient relationship, keeping information confidential, mutual respect, building a relationship with a new culture. Patients should be treated as unique individuals, treated equally, and relationships are kept in the boundaries of the care setting. When appropriate, make the patient have the opportunity to make choices. In multidisciplinary relationships, just make sure that everyone on the care team is in the same realm of believing in the cultural practices of that individual. You don't want somebody to come in without respect. Respect of others' opinions, respect that respect does not equate with agreement. Support each other and keep the patient's best interest in mind. If you need to, you can always consult the ethics committee, and that should take place when differences are identified between the care providers and the families and the care providers that are in that person's care. Sometimes building a new relationship with a patient from a different culture may feel really uncomfortable, and that's okay. It's because of your own uncertainty and mental strain involved in interpreting and understanding the culture in a manner that's organized and makes sense to you. But it is certainly okay to have different cultures and different thought processes, but at certain points in time, you may have to exclude yourself from that patient's care for the patient to get the best care. Language barriers, again, remain calm, contact an interpreter. Hand gestures mean different things, so don't try to do hand gestures. Allow the parent to remain with the child. Use touch and facial expressions. We can use pictures. Pictures are only a temporary intervention. You and the parent or caregiver may point at pictures to communicate if immediate interventions are needed. Use the internet for basic interpretation of words, and do not provide elective procedures without consent of the caregiver. So I know that a lot of people use Google Translate on their phone. Just be careful of that, because if it has anything to do with signing a consent, you probably are not going to have that stand up in court. So if it's truly an emergency, we can always go to the ethics committee. We can always do a what's right for the patient kind of idea. But at the end of the day, the parent has to be informed. So just remember that behaviors and characteristics determined by culture, personal space, eye contact, diets, time, touch, and the use of alternative medications. So always be aware of that person's beliefs and what they want, determined by their culture. Personal space, big time. Diet, just make sure that we are asking them what food practices. It may include 2 separate refrigerators. Time is very different. I know in Montana, up in the native population, time was a big deal, because if you set an appointment for 9 o'clock, they may not get there until noon, and they think that that's okay. It's not okay in the white society, but that is a normal thing for a native. So knowing when is best for them to get a ride to come in is more important than setting a date and a time. So asking them, is afternoon better, instead of just putting them in an appointment. I know myself, I hate that when somebody puts me in an appointment. They have no idea what I'm doing during the day, right? People work. There's a reason why there's after office hours. Okay, so let's go on to clicker check. Which of the following best practices related to effective communication? Which of the following best practices? Respect differences of opinion, recognize appropriate boundaries and maintain those boundaries, know who's responsible for making healthcare decisions. So while all the options are best practices, knowing who is responsible specifically relates to effective communication. So these are great, but they didn't have anything to do with effective communication. Okay, that's how they can trick you on the test questions. The only one that had something to do with communication was A. Cultural assessment is a mechanism through which we can gather subjective data to identify beliefs and values about the patient's culture. So the Giger and David Hage transcultural assessment model, it uses communication, space, biological variation, male, female, time, control, and social organizations. So just having a little talk about communication and how thoughts or feelings are expressed, personal space, what's appropriate for weight and development, what is the perception of time, especially meal times, and the degree to which the individual feels they can influence the environment or their experiences. Social organization that the parents are part of, like religious and social groups, are really important to know. What defines the family? What is their spirituality? What is their environmental considerations? If they don't have control over water and adequate drinking water, why are we sending them home with meds that are not already pre-mixed or in liquid form already? Inadequate medical help during emergency situations, inadequate police coverage in their neighborhood, gas and chemicals released by local industries, and the lack of availability to trauma centers for critically ill patients, safe areas for outdoor play, the employment status, the social economic status, and the family composition should all be in that assessment model. The FICA assessment tool is about faith, belief, importance of that faith and belief, the community that is involved, and address and care. So that one you really want to ask, do you consider yourself to be spiritual? What gives your life meaning? What importance does spirituality have in your life? Are you part of a spiritual community? And then A would be, how would you like me as your healthcare provider to address your spiritual issues in your healthcare? So then they can tell us what we need to do. Instead of walking in and saying, tell me all about Muslim, tell me all about Buddhist, tell me all about Catholics, right? It's another way to do the FICA assessment tool. So you should probably look that up. It might be on the test. A cultural assessment should evaluate which of the following areas: religious, food preferences, typical daily schedule. We just talked about this. So it should affect all. You should ask about all of those. So in summary, in this chapter, we covered culturally competent care, cross-cultural communication, and cultural assessments. Now you should be having a little bit better knowledge on how to ask those questions, what to say, what not to say, what to avoid when further assessing your patients. Thanks.